Hi, my name is Hal Egbert, physical therapist here at United Physical Therapy Midtown, and I'll be talking today about 4 different parts of the forefoot for you as a patient or a practitioner to use for reference in understanding both the anatomy and the options for doing an examination, as well as some treatment protocol or some ideas that can be useful for your management, and lastly, what type of footwear considerations might be helpful. And today we also have John Egbert, who's a physical therapist, who will be using his foot as a model. This is the first part on anatomy, and on the first part of the anatomy we're going to have John standing so we can refer to his whole limb. If you look at John's standing position here, his feet are about shoulder width apart, and John, if you could drop your hands to your sides. And the areas that we're going to be looking at are how he has control of his hip, his knee, his ankle, and his foot, and how he balances particularly. So if John, if you could just kind of sway over to your right foot mostly, left foot, okay. Now could you stand on your right foot only and then just squat down a little bit? In this position, if you look at John's foot position down here with his big toe along the first ray and his rear foot, we're checking to see his ankle into flexion, his situation with his bearing weight through the lesser toes and his great toe, checking the amount of blood that's being taken away from his nail beds if he's pushing down hard with his big toe or second toe. And then he's touching the bed, so he's trying to get control of his foot. So let's take your hands away and take your bottom away from the bed. So now he's unstable, and you can see how his alignment is changing. So as he's balancing, he's using his hip, his knee, muscles of his lower extremity, and particularly he's kind of going over to his right side of his foot, outside or the inside. Now if you could turn your shoulders a little bit to the right, John. That's engaging more rotatory, and he's trying to control that. And his second toe is white, but his big toe isn't so much. Let's go over to the other side with your trunk. And in that position, we're still seeing him engage his medial foot, first ray, second ray, ankle, knee, and hip in balancing. That's good, John, thanks. Okay, now we have John lying down, so we're going to be checking the metatarsal heads, the big toe, the base of the big toe, sesamoid bones, the situation of how his foot is aligned with high arch, pes cavus, or low arch, flat foot. We're talking about its dorsum of his foot, talking about the metatarsals and how they feel to palpation later on, talking about the position of his forefoot to his rear foot. So all these things have a different terminology. A neutral rear foot is when the heel does not supinate or pronate. It's in a neutral position for the talus and a neutral position above my fingers here. What we have with the forefoot would be a medial downward tilt, which would be pronation, or an upward tilt, which would be a supination. And for the arch of the foot, John has a particularly high arch called pes cavus, which leads him to have quite a bit of more pressure on his big toe side and a little bit on his lateral fifth, but less so on his lesser toes of 4, 3, and 2. We've already checked the fibula, the tibia in positions that have functioned, both standing and enduring gait analysis, as well as checking his hip mobility and pain, also checking his leg length, checking for any sort of scars from surgery, any sort of skin lesions that would be demonstrating issues of the skin not getting good circulation. So at this point, we're going to actually just feel his skin lightly, just to see how it's doing, for how much thickness is over his skin, as well as his heel, for fissures, cracks, but mostly looking at the forefoot. And in this position, we're going to be referring on to this slide over here. Here's some of the anatomy of the forefoot that might be helpful for a painful foot of a neuroma style pain. We have the metatarsal number 1, metatarsal 2, 3, 4, and 5. You have nerves coming down to those areas of the body from the medial plantar nerve over here and lateral plantar nerve. And at the base of his metatarsal heads, you have transverse intermetatarsal ligaments that hold them together. There are splits of those nerves that go on to the tibial side and the fibular side of his metatarsals on each toe, and they are a source of pain and entrapment, particularly causing them nervy pain or neuroma-style pain that is common with forefoot pain. On the top of the foot, we have the extensor tendons that you can see. We're looking for deformities of his toes, which he doesn't have, looking for valgus and varus of his great toe, which is in a neutral position. And this will be the common area for neuroma pain, would be between these tendons into the area between the metatarsals. And what I'm doing is just rubbing gently between them to see if there's much pain. There isn't any pain. Another technique to provoke this area would be to move your hands to the side of the foot and then squeeze in. This would be a medial to lateral compression. If there is neuroma pain, it's frequently tender. Thirdly, taking one metatarsal with the other next to it stabilized, you can shear one metatarsal on its neighbor. And sometimes you feel a click or a painful sensation and the patient winces, and that demonstrates that you have some forefoot pain that's in the metatarsal area. And that's the dorsum palpation. The plantar palpation is similar in that you go between the metatarsals and engage the tissue between, but staying off the metatarsal heads. Lastly, checking the metatarsals. If you go to the callus and check the callus to see if underneath the callus there's pain, or the lesser toes that don't have calluses. As we get over to the callus of his great toe, I'm actually moving that callus across his metatarsal head and then coming back off that callus towards his heel and pressing in there. If you're off the head and it's towards his heel and you're having some sensory burning pain, this can be an irritation of the medial plantar nerve as it goes through the sesamoid ligaments. On the second head, it's common that a second head will be more prominent for a callus than the great head, as the great head doesn't engage the floor as well, and he has no callus on the second. And the other option would be in this position now, I would take his plantar metatarsal head and stabilize it and then pull his toe over that and engage the toe with a little bit of distraction. If this is positive, then his symptoms may very well be of his joint capsule of his metatarsal phalangeal joint or MTP joint. So flexion with distraction over your stable base that's being pressed upon with your palpating thumb. Moving the fibular sesamoid around versus the medial tibial sesamoid gives you a sense of how irritable the sesamoid is on the great toe. So in review, we've got dorsal palpation, plantar palpation, compression medial lateral, shear, and then on plantar palpation we just go ahead and switch over to the examination of the metatarsal joint. If you are thinking of nerve pain as being part of the neuroma-like pain, then you also would want to include some palpation of your sural nerve as it exits through the fascia about 10 to 13 centimeters proximal to your lateral malleolus. And if you sweep that area, the sural, S-U-R-A-L, sural nerve is directly under your skin, and this will actually induce some tingling and pain in the lateral foot. On the medial side, if you could turn your leg, John, a little bit, can you see that at all? Well, let's go to this foot. For the medial foot, we're coming down through the medial malleolus area, and it forms a tibial nerve, crossing underneath the medial malleolus at the lanceolate ligament in this area, and forms a nerve bifurcation in this area to the medial and lateral plantar nerves. It also can be touched in this area and up through that lanceolate ligament and even up into the posterior malleolus. Any of these areas can be a site of entrapment for a nerve that goes to your forefoot, and it would be called the tarsal tunnel syndrome. And if you tap that area in any of these zones, and if you get your Tinel's, T-I-N-E-L-S, symptom of tingling or burning in your forefoot, then we have to think about your forefoot pain as being more proximal in origin.